So in our previous video, we talked about some complications of high blood pressure. In this video, we're going to continue that talk. We're going to talk about some common side effects of high blood pressure, which is sclerosis, hardening of your vessels. If it hardens your arterioles, we call that arterial sclerosis. If it hardens your larger vessels, we call that atherosclerosis. Let's just talk about arterial sclerosis first. So this is sclerosis of your arterioles. All right, your smaller vessels. And there are a few types. There's hyaline. So here's your lumen. There's high blood pressure. It'll push proteins into the wall. So proteins in wall. And you can actually see those proteins on histology. It'll look pink. It'll look pink. So you get these little hyaline blobs. Great picture will be in my notes. So I'll just write pink. Okay. If you ever see big pink blobs, it's hyaline. Easy peasy. And that goes beyond arterial sclerosis. Just keep that in mind. You can have a different type called hyperplastic. So let's just reset. Here's our blood vessels. And our blood vessels have three layers. We have our inner intima layer. We have our middle muscular layer. And then we have our outer layer, right? If you have really, really, really high blood pressure, pushing against these walls, your body will freak out and says, I can't stand this. I need to reinforce it somehow. And so it will recruit your middle layer, that's your muscular layer. It'll recruit more smooth muscles to kind of brace it, kind of reinforce your blood vessels. And it will make more and more, and you get this kind of onion skinning. So I'll write, recruit more smooth muscles equals onion skinning. Now, it's not going to be 100% perfect. Sooner or later, these vessels can pop, they can burst, they can hemorrhage. And when they hemorrhage, you'll see it, right? The one they like to talk about is your kidneys. When they hemorrhage, they'll have these little dots of hemorrhage, and it looks kind of like they're bitten by fleas. They call it flea-bitten kidneys. Flea-bitten kidneys. So you see kidneys like that, you see onion skinning on histology, hyperplastic arterial sclerosis. There's one more type of sclerosis hardening, and that is called Mockenberg. Just like that name. Let's just reset. Here's our arterial with our three layers. This is when there's calcification in the middle layer, the medial. Mockenberg is named after the person that discovered it, but the scientific name is medial calcific sclerosis. Literally, calcium in the media causing sclerosis. So you have all this calcium deposited, and you can actually see it. You can see it. You can see calcium on X-ray, right? So X-ray shows these calcified lumens, calcified vessels. And they will harden because it's ours. And they will harden because it is sclerosis, but something you should know, it only affects the middle layer. Your lumen is just fine, doesn't narrow the lumen as opposed to the other ones, doesn't narrow the lumen. So lumen not narrowed. That's arterial sclerosis. Let's talk about atherosclerosis. Athero means gruel. And that term, the gruel part, comes because in these vessels you see these little yellowish, nasty plaques that look kind of like gruel. How do we form these plaques? Let's pretend we don't have that plaque to start with. In high blood pressure, you can rip a little hole in your intima. Not dissection, just a little hole. Just a little hole. So, all right, intima damage. And when you rip that little hole in your intima, then fat like LDL will get under it. Get under it. Get under it. Okay? So, all right. LDL enters, and your body knows that's not normal, so your macrophages come in and eat it. Macrophages come in, eat. They come in and eat. They eat all your LDL. They eat it so much that they actually die in the process. Right? It's like a person that went to the buffet a little too hard and they died in the process. And when they die, you can still see all that fat in them. I mean, why wouldn't you? So you see all this fat in them, and they are now called foam cells. They look kind of foamy. Now your blood vessels look like this. There's a little streak of fat in your blood vessels, and we call that the fatty streak. Fatty streak. It just kind of lays there, and all the blood and all the things in your blood will move past it, and platelets will hit it. Platelets will hit it. And when platelets hit it, they release something called platelet-derived growth factor. So platelets land and they release platelet-derived growth factors. And what does platelet-derived growth factors do? They recruit smooth muscle. Recruit smooth muscle. Smooth muscle in your middle layer. And they will sense this and chemotactically move towards your intima. So smooth muscles move to the intima where all these growth factors are being released. So they start to migrate up to the intima, migrate up to the intima. And after they do that, they will release proteins, fibrous proteins, which create a cap over this fatty streak. Create a cap over this fatty streak. And that we call our cholesterol plaque, our gruel that you see in our blood vessels. The gruel that you see in our blood vessels. All right. So the cholesterol plaque is made up of that fatty streak and the cap. So, all right, the streak and the cap. And that's our gruel in our vessel. And the thing is, that gruel, that atheroplaque will narrow the vessel, right? Narrows the vessel. And when you narrow a vessel, what happens to your blood pressure? It rises. And if you have increased blood pressure, you can have intima damage and starts this pathway over and over and over. And it's kind of like a vicious cycle. Okay, so that's one side effect of having that plaque. Another side effect is that this fibrous cap isn't very sturdy. This could pop open at any second and all that gunk can go out. That's not good. If all that gunk goes out, it can cause a blood clot. We call blood clots thrombosis. It can cause a thrombosis. You get a blood clot, okay? This blood clot can break off and move, can embolize. And you know an embolus is from this fatty streak because it'll have a ton of that LDL, a ton of that cholesterol in it. All right, it'll have cholesterol clefts. Great picture of cholesterol clefts will be in my notes. You see someone with an embolus, you cut that embolus open and you see cholesterol clefts, and they'll ask you, where did it come from? It came from a cholesterol plaque. They also like to ask the most common locations of atherosclerosis. The most common location is in your abdominal aorta. Maybe it's due to that lack of elastin, maybe it's due to the lack of vasovasorum, making it weaker, making the intima damage easier. Whatever the case, abdominal aorta is the most common place, and you need to know that. Second most common, coronary arteries. The arteries that supply your heart. That is not good. Third most common, it's going to be your popliteal. The last one you should know is your carotids. Your carotids. You get plaques there, and that plaque can break off, go to your brain, embolize in your brain, causing an embolus with cholesterol clefts, stroke, death from carotid plaques. Now, what are some risk factors? Well, we talked about some. We talked about hypertension. But anything that damages your blood vessel, anything that causes intima damage and starts the process can cause these plaques. That includes diabetes, because diabetes can damage your vessels. That includes smoking, because smoking is a toxin that can damage your intima, your blood vessels, start this process. Increased LDL. LDL is the thing that enters. So if you have increased LDL, it just enters more, creates more plaques. These are factors that are modifiable. These are factors that you can change. Some things you can't change, some things that are non-modifiable are going to be your age, your family history, and your gender. I want to finish this talk with a talk on hyperlipidemia and hyperlipidemia drugs. We said that increased LDL can predispose you to all this, right? Because LDL is the fat that goes in. So if someone has increased LDL, we might want to give them drugs to kind of decrease that fat, decrease that LDL. So let's talk about that now. I'm gonna give you a quick recap on fat metabolism and transportation. You eat a big fatty meal, goes to your gut, gets broken down. You get a bunch of fat, cholesterol in your blood, and this is not water soluble. Yeah, you can't just leave it there, it'll just precipitate out. It's not water soluble, so we have to transport it with proteins called lipoproteins. These are your chylomicrons, your VLDL, HDLs, LDLs, all that good stuff. And we transport it into our liver. And we need this. We need fat, we need cholesterol because they're very important. They're very, very important. Cholesterol, as you know, help make up our phospholipid bilayer, makes up hormones, makes up a ton of things. And in our liver, it also helps make bile. Right? So it has a ton of functions. And if it doesn't get enough cholesterol, your liver can actually make more cholesterol, make more fat, because it's so important. It does this by turning acetyl-CoA into HMG-CoA, and that gets worked on by HMG-CoA reductase, an enzyme that works on HMG-CoA, turning it to mevalonate, and that eventually becomes our cholesterol. So it can make more cholesterol if it needs to. That's how important it is. Not only for the liver itself, but if our body needs it, it will package that cholesterol and send it out. Can it just send cholesterol by itself? No, it's not water soluble, right? So it has to send it with transporter protein. So it can send it out as VLDL. And it goes into our tissue, and our tissue has enzymes that can pull this fat from this transporter called lipases. There are different types. There are lipoprotein lipases. There are hormone-sensitive lipases, so lipases that respond to hormones. That way you can kind of your body can kind of control the rate. And when it breaks down and takes fat from VLDL, that will become IDL, or intermediate density lipoprotein. You take fat from there, it becomes LDL. And that LDL is eventually recycled. Okay. Any excess fat is taken up by HDL. It's all right, takes up excess fat. Because HDL takes up excess fat, we sometimes call this our good cholesterol. Because LDL transports fat. If you have too much LDL, we know that you have too much fat transport, and LDL we call our bad cholesterol. Okay, so we want to lower LDL, which we kind of talked about. Too much LDL kind of goes and creates those plaques. So we want to lower LDL, and we want to maximize our HDL. All right, let's talk about some drugs. I think that's enough. Just a quick recap on our fat transport. Let's talk about some drugs. Our biggest drug is statins. All these drugs end in the word statin. And these are HMG-CoA reductase inhibitors. You block this enzyme, you don't make cholesterol. That's the rate limiting enzyme. That's the most important enzyme to making cholesterol. You block that, you don't make cholesterol. block enzyme. Okay, that just lowers your LDL, just lowers this pathway. Some side effects you should know. Some side effects: it is not a friendly drug for your liver where it works, so it's hepatotoxic. And also, cholesterol and fats needed to make a certain compound in your electron transport chain. That's the whole ATP chain. All right, we're not gonna get into biochemistry in this video, thank goodness. But if you don't have that ATP, your muscles starve, your muscles die, you get myopathy. Myopathy is a huge side effect. They like to say, okay, a patient was given statins, what kind of labs do you monitor? You're gonna wanna monitor creatinine kinase for muscle damage. And throw in liver function tests, LFTs, why not? Because it causes hepatotoxicity. That is a side effect you gotta know cold, commonly asked. Second drug, let's talk about something called ezetimibe. Hopefully I'm pronouncing that right. Ezetimibe blocks cholesterol reabsorption in the gut. Stops gut reabsorption. Done. That's all I have to talk about ezetimibe. What a great drug. Next one is bile acid resins like cholestyramine. This stops the reabsorption of bile acids, so I'll say stop bile acid reabsorption. And your body runs out of bile acids. And your liver freaks out and says, I need to make more. So it makes more, uses cholesterol to make more bile. And because of that, you pump less cholesterol out, all right? So you kind of divert it into making more bile. Clever, clever. So use cholesterol to make bile instead of pumping it out. Some side effects: stopping bile acid reabsorption. Bile acid usually breaks down fat. If you don't have that, you get fat malabsorption. The way they ask this, they'll say someone's taking cholestyramine, what are they going to be deficient in? Fat-soluble vitamins like A, D, E, K. Or a more clever way, they'll say someone's taking cholestyramine. They'll talk about side effects. They're having these really bad flatulence and really fatty stools. And then they'll flip the script and ask you where bile acids are reabsorbed in. And you're like, oh, wait, what? I wasn't expecting that. Where are bile acids reabsorbed in? That'd be your ileum. Your ileum. Okay, that's where it takes place. So just, you gotta be on your toes when they ask these questions. They can really throw you a curveball. Just be on your toes. Ileum. Next drug, it's gonna be fibrates. Fibrates, and these all end in fibrate except for one jerk that didn't get the memo called gemfibrozil. Gemfibrozil. This actually works on genes that modulate fat metabolism. Modulate it to our advantage, and actually helps increase HDL, decrease LDL. So works on genes, in particular a gene called PPAR alpha, or peroxisome proliferator activated receptor alpha. And that gene helps modulate our fat metabolism to our advantage. You don't need to know how, just know to recognize this on answer choice. Fibrates, PPAR. Fibrates, PPAR. It takes some time because it has to work on genes, but can work well. Some side effects: myopathy. What other drug that did we just talk about causes myopathy? Can you tell me? If the statins, you were right. What do statins do? Can you tell me? Block this enzyme. So they like to ask these two together. They'll talk about someone taking a statin, having muscle breakdown. What do you avoid? You avoid fibrate, because that also causes muscle breakdown, makes things worse. All right, or they'll say you're avoiding a second drug. What does that second drug mechanism do? Activate PPAR alpha. Many ways to throw it at you, but if you know these few key facts, can't go wrong. Our last drug, and then we'll be done, it's gonna be niacin. Niacin is actually a vitamin. That's vitamin B3, right? I got a question. They said someone has hyperlipidemia and you want to give them a vitamin to stop it. I was like, wait, what? There are vitamins that can stop it. They're talking about niacin. They're talking about niacin. It seems to inhibit hormone-sensitive lipase. Hormone-sensitive lipase. These are the enzymes that pull fat from the transporters. Pull fat from the transporter. You stop that, then you stop pulling fat from them. Okay? You stop pulling fat from them. Some side effects. Hyperglycemia. The exact mechanisms not well known, but the other mechanisms for other side effects are well known. Hyperuric acid. Niacin competes against it in the renal tubules, so you get increased uric acid. What does increased uric acid do? Cause gout. Can you think of how they might ask that? Someone has hyperlipidemia, you give them niacin, and then all of a sudden they develop painful big toe. What happened? Increased uric acid. And then another side effect that you should know is that you get flushing of the face. It increases prostaglandins. All right. How do you reduce that? Well, you want to block prostaglandins. The easiest way, NSAIDs, over the counter. NSAIDs, block it. So, how do I like to ask this? Someone has hyperlipidemia, you gave them niacin, they have flushing. How do you avoid the flushing? Pop a NSAID 30 minutes before, done deal. That does it for atherosclerosis, arterial sclerosis, the drugs for hyperlipidemia. Hope you enjoyed the video. Thanks.